Hello, how's it going? Today's a nice day to talk about antipsychotics, so I hope you're here with me. This is a long presentation, but I go into depth about quite a few antipsychotics, and hopefully we can learn the differences between a few of them. So the objectives are to introduce the pathology and symptomology of schizophrenia. We'll spend a short time on that. Discuss the use of antipsychotics and the guidelines on how to prescribe antipsychotics for schizophrenia. We'll also talk about the uses of antipsychotics in other disease states. We're going to discuss some of the current literature for different treatment strategies when using antipsychotics, especially in the subdomains of schizophrenia, depending on symptomology, which antipsychotics may be better. We're going to discuss the dosing and formulation of antipsychotic drugs, and we're going to describe the differences between second generation antipsychotics and first generation antipsychotics. And we're going to discuss the unique pharmacology, pharmacokinetics, and clinical effects of selected antipsychotics. I'm going to provide information to you about antipsychotic therapeutic drug monitoring and its place in practice. And then we're going to talk a little bit about the long-acting injectables and which antipsychotics are available for long-acting injectables and when we might use a long-acting injectable over the oral form. And finally, we're going to talk about strategies for discontinuing or switching antipsychotics. Antipsychotics, in addition to there being many antipsychotics, they also come in different formulations, and some antipsychotics can come in more than one formulation. And they're used to treat a number of psychiatric disorders as well. Katie is one of the most well-known studies of antipsychotic effectiveness in schizophrenia. It compared first generation and second generation antipsychotics, and it failed to show a significant difference between them in decreasing positive symptoms. However, there were subdomains that did benefit from one antipsychotic over another. In addition, some head-to-head trials of antipsychotics show benefit of one over another for some domains in schizophrenia, like somebody having a lot of cognitive issues or someone having a lot of affective issues. There are a variety of dosing strategies to provide the most clinical benefit to the patient. And the choice among antipsychotic drugs depends on a number of factors: patient's preference, their adherence, difference in adverse effects, and possible differences in efficacy in some patients, the patient history, formulations, and one thing we don't like, but it is a factor, is the cost and availability of drug formularies, or the patient being able to afford the drug as well. So the pathology of schizophrenia, there's a handful of hypotheses. These are a few of the major. There's the serotonin hypothesis. A lot of antipsychotics inhibit a serotonin receptor, and LSD, which some scientists use to mimic symptoms of schizophrenia, is a serotonin receptor agonist, and they believe overactive serotonin subtypes could be responsible for hallucinatory effects. So serotonin antagonist properties are found in many antipsychotics, especially these second generation ones. And Nuplazid, or pimavanserin, is an antipsychotic that's a pure serotonin antagonist that's used for Parkinson's psychosis. So the dopamine hypothesis is no longer adequate to explain all aspects of schizophrenia, especially the cognitive impairment. Many antipsychotic drugs strongly block postsynaptic dopamine 2 receptors in the central nervous system. This is a common theme among all antipsychotics to some degree. Some are partial agonists, some are full antagonists, some are irreversible antagonists, some are reversible. But they all share the common theme of dopamine 2 receptor blockade, except for Nuplazid, which is a serotonin antagonist. Drugs that increase dopaminergic activity can aggravate psychosis or produce psychosis de novo in some patients. Like if somebody is on bromocriptine or amantadine, they may develop psychosis for it being a dopamine agonist. And then there's the non-competitive N-methyl D-aspartate receptor hypofunction hypothesis of schizophrenia. PCP, or phencyclidine, is a hallucinogenic illicit drug used by some people for enjoyment, but they believe it mimics the symptoms of schizophrenia in all facets. Like it mimics the cognitive impairment, the affective symptoms, and also it mimics the positive symptoms as well. And then there's the neurodevelopmental theory. Symptoms of schizophrenia are the end result of imperfect neurodevelopment. Antipsychotic medications provide symptoms of relief but do not address the root cause, and this theory is picking up steam, and practitioners believe that the neurodevelopment theory at least plays some part in the pathology of schizophrenia. Let's look at the symptoms of schizophrenia. Schizophrenia is an overlapping illness that encompasses positive, aggressive, negative, affective, and cognitive symptoms. They often overlap and are difficult to distinguish. Positive symptoms include delusions and hallucinations, and aggressive symptoms is kind of offshoot of positive symptoms. It's believed in someone who has schizophrenia who is aggressive, kind of reining in the positive symptoms will help control the aggressive symptoms, such as assaultive and verbally abusive. But there are some antipsychotics that may be better for aggression than others. And then there's the negative symptoms, which include reduced speech and range of emotions, loss of interest, loss of social desire, and loss of motivation. And this can be an offshoot that can lead into anxiety, suicidality, and depression, which are the affective symptoms. And then the poor attention, impaired executive function, are cognitive symptoms. So all of these overlap. And because of this overlapping illness, we're now starting to look at schizophrenia and bipolar as a spectrum disorder, because schizophrenia can have the affective symptoms that bipolar can have, and bipolar patients can have psychotic features as well. So we can diagnose somebody as schizoaffective disorder bipolar type or schizoaffective disorder schizophrenia type. So to wrap it up, common overlap in symptom presentation and comorbidity between schizophrenia and mood disorders support the ideal that these two disorders are part of a continuous spectrum, which we just said. So here is just a list of brand generic names of selected antipsychotics. We distinguish between the first generation antipsychotics and the second generation antipsychotics. We could even break this down further into each of the drugs' chemical class, especially with the first generation antipsychotics, but we'll talk about that a little more. Haloperidol, for example, is a butyrphenone, and then there's the phenothiazines such as chlorpromazine, perfenazine, and fluphenazine. So we may touch on that. And this is just a list of all the disorders or illnesses or all the uses that antipsychotics have to treat a certain condition. Of course, we see antipsychotics in schizophrenia and bipolar, but we also see antipsychotics, especially Seroquel, can be used in anxiety disorder, especially if somebody has comorbid bipolar. And then there's depression, obsessive compulsive disorder. They recommend antipsychotics. Haloperidol is one, olanzapine, Abilify. Insomnia, dementia behaviors, autism, delirium in the ICU or hospitalized patients, Tourette syndrome, and even control of nausea and vomiting. So there's a lot of practical uses for antipsychotics as a drug class, not just for schizophrenia. There are some guidelines we can look at that give recommendations on how we should initiate an antipsychotic and what paths we should take in treating a patient who has resistance to an antipsychotic. There's a handful of different guidelines. They all have similar recommendations with a few tweaks. All the guidelines unanimously recommend a second generation antipsychotic first line. A couple of the guidelines recommend specific antipsychotics first line, such as port. They recommend second generation antipsychotics other than clozapine and olanzapine, but they also recommend first generation antipsychotics as a possible first line, while other guidelines don't recommend first generation antipsychotics until the second line recommendation. And then WFSBP guidelines, they'll single out an antipsychotic that they recommend for first episode, which they feel like has the most efficacy: olanzapine, Seroquel, risperidone, or haloperidol. And then the multi-episode, any second generation antipsychotic, and they exclude lorazepam because at the time of this guideline being published, there was only limited amount of evidence to show its efficacy in multi-episode schizophrenia treatment. And then third line, most of the guidelines, actually all the guidelines on this slide unanimously have clozapine third line. A couple of the guidelines, such as the APA and WFSBP, recommend clozapine possibly second line, but clozapine is usually reserved third line due to it having a lot of adverse effects, even though it is a well-tolerated drug and it is one of the most efficacious, if not most efficacious antipsychotic. It does come with the possibility of severe side effects. And then fourth line, clozapine augmentation. And then if there is a fifth line, they recommend combination therapy and high-dose antipsychotics. WFSBP recommends electroconvulsive therapy, which has a lot of good evidence for its use. And I think something like 50 to 70% of patients respond to electroconvulsive therapy while also being on antipsychotic. So it does have a very successful response rate. NICE guidelines are unique because first line they recommend that an antipsychotic be used with psychological interventions. Some patients may benefit from psychological interventions, such as realizing that they do have this disorder, it's a lifetime disorder, and need to take antipsychotics, or just have someone to talk to about it, but it's debatable about the efficacy. Here is another example of a treatment guideline for schizophrenia from the Texas Department of State Health Services. They recommend certain antipsychotics first-line trials such as aripiprazole, olanzapine, Seroquel, risperidone, or ziprasidone. So they list it. In stage 2, if they're treatment resistant to stage 1, try a different antipsychotic, including a first-generation antipsychotic. Stage 3, clozapine. Stage 4, clozapine augmentation. And then stage 5, pretty much go back to the drawing board and try another antipsychotic that hasn't been tried before. And then stage 6 is where we see some more augmentation strategies, such as combination antipsychotics using electroconvulsive therapy, or augmenting with a mood stabilizer such as Depakote or lithium. This is an example of another guideline I found in one of my textbooks. They separated stage 1A and 1B by treatment-naive individual with first-break schizophrenia. They recommended aripiprazole, risperidone, or ziprasidone. And then there are those who have previously been treated for schizophrenia and the antipsychotic is being restarted, and they recommend any antipsychotic except clozapine. Preferably use an antipsychotic that has worked for someone in the past. If the patient has had an inadequate response to stage 1, we recommend trying a different antipsychotic. And these guidelines say we can consider clozapine in severely suicidal patients with schizophrenia. Clozapine has shown efficacy in decreasing suicidality in schizophrenic patients, so we can consider it in that patient population. Stage 3, clozapine monotherapy. And then when we get to stage 4, they kind of back out of a recommendation. They say minimal evidence exists for treatment options for patients who have not received an adequate treatment response with clozapine. And they go back to the drawing board with augmentation strategies or antipsychotic combinations, nothing specific. And in the side, they have the recommendation of using a long-acting injectable to improve poor patient adherence or because of a patient preference. Let's look at what the evidence says for multiple antipsychotics. Antipsychotic polypharmacy is a frequently used practice in treatment-resistant patients. Unfortunately, it is often necessary. However, clinically no evidence exists to prove that antipsychotic combinations are superior to monotherapy, and the 2009 port recommendations do not support their use. Some data, although limited, do however show that antipsychotic polypharmacy was superior to monotherapy in treatment-resistant patients and in forensic patients. Combining antipsychotics can lead to high overall dose and an increased burden of adverse effects, along with an increased risk for drug-drug interactions, as well as variability in serum levels and increased pill burden. There are some strategies to determine a total daily antipsychotic dose equivalent. I think it's called the BDF factor or something, which no matter what the dose of the antipsychotic, if somebody's on 2 antipsychotic, it still has to add up to a BDF factor of 100%. If it goes over that, then they're on too high a dose of the combined antipsychotics. So it's an interesting measure. If clinicians do decide to use combination antipsychotics, they should be guided by the pharmacodynamic profiles of the antipsychotics, which we'll talk about. And the aim is using antipsychotics that have different receptor binding profiles that are not overlapping as much. When determining which antipsychotic to decrease dose or discontinue, we need to factor in the antipsychotic's adverse effect profile, antipsychotics' effects on the various symptoms of schizophrenia, and patient-specific needs. Basically, in conclusion of looking at the evidence for multiple antipsychotics, it can work for some clinically difficult conditions, but should be the exception rather than the rule, and may be avoidable in many patients. What do we take into account when we're initiating a patient on an antipsychotic? There are a number of factors we need to look at. The first factor is efficacy. What antipsychotic would be the best for the patient with the symptoms they are displaying? Are they being more aggressive, so would Geodon or olanzapine be better? Or are they having more negative symptoms, so potentially cariprazine would be a good choice? We also need to know the patient's history. Have they responded to an antipsychotic in the past? What hasn't worked? What has worked? The available formulations of an antipsychotic are also important. Do we eventually want to transition the patient to a long-acting injectable? So it would be good to select an antipsychotic that has that formulation. And also we need to know the side effect profile of the antipsychotics to help us mold our decision. And like I said, targeting positive, negative, or cognitive symptoms is another factor we need to consider. Patient-specific needs, we need to think of drug-drug interactions, and there's actually little guidance on when to use which antipsychotic. So that's why I say psychiatry, a lot of it's art, and out of all medicine, I feel like nothing is clear-cut with psychiatry. It's like each patient is a unique patient. They're like a unique snowflake. I hate to use that analogy, but it's really art. We have to paint a nice picture for the patient that they'll respond to, and it's a team effort when treating a patient, and the patient is a huge part of the team as well. And we also need to consider kidney, liver impairment, or other comorbid disease states such as dementia, diabetes, high blood pressure, low blood pressure, rheumatoid disorders, you name it. So this slide, we looked at the formulations of the first generation antipsychotics. So we can see that some of the antipsychotics, they come in tablet form, some come in liquid form, some like haloperidol come in an immediate acting injection and also a long acting injectable. And each of these formulations have FDA recommended max dosage, but oftentimes we'll see that the FDA studies that determine the most efficacious dose may not factor in treatment resistant patients, so a lot of times patients respond to a higher dose of these antipsychotics. But here are the available formulations of these select first generation antipsychotics. Loxapine is the only antipsychotic that comes in an inhaled form, and we don't see it used much. It has a REMS program, which is a risk mitigation strategy. A patient, if they're taking loxapine for acute agitation, they inhale it, they have to be monitored for 15 minutes after the inhalation, and it's definitely contraindicated in somebody with COPD. We also look at the formulations for the second generation antipsychotics as well. We see a lot of these come in oral dissolving tablets as well as long-acting injectables. Abilify is unique because it came out with a tablet that has a sensor in it. So if a patient is taking the tablet with a sensor, it could notify the physician if they miss a dose or if they aren't being adherent. I haven't seen this used in practice. I just saw it in a news article and found it interesting. Antipsychotics, for the most part, share the common mechanism of being a dopamine 2 receptor antagonist, or some are partial agonists. They decrease dopaminergic transmission in several areas of the brain, including the mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular. The mechanism of action of these antipsychotics is based on the hypothesis that schizophrenia involves a dysregulation of neurotransmission and brain dopaminergic circuits with excess dopaminergic activity in the mesolimbic pathway and reduced dopaminergic signaling in the mesocortical pathway. So research suggests that the mesocortical pathway is associated with cognitive impairments and disturbances of emotions and affect, such as negative symptoms. Blockade of the mesocortical pathway by high doses of first-generation antipsychotics can induce secondary negative symptoms and cognitive effects. The pathophysiology of positive symptoms of schizophrenia are thought to due to overactivity of dopamine in the mesolimbic pathway, so blockade of the dopamine 2 receptors in the mesolimbic pathway has been proposed as a possible mechanism of antipsychotic action of first-generation agents. Antagonism of dopamine receptors in the nigrostriatal pathway is associated with increased risks of extrapyramidal symptoms. And in the tuberoinfundibular pathway, dopamine blockade can lead to hyperprolactinemia. Dopamine acts as a prolactin inhibiting factor. Dopamine blockade increases prolactin levels by promoting its release in the pituitary gland. So dopamine can have an effect on a number of different pathways in the brain, and dopamine blockade is associated with the relief of positive symptoms, but pure dopamine blockades can have side effects and worsening effects that we don't want as well. So these second generations have serotonin antagonism tied to them, which can help increase dopamine in the parts of the brain that are low in dopamine. There are some main differences between atypical antipsychotics versus the typical antipsychotics such as Thorazine or Haldol. The concept of atypicality is thought to be due to two properties. First, their low affinity for dopamine 2 receptors compared to their affinity for serotonin 2A receptors. There's a higher serotonin 2A receptor to dopamine 2 receptor, and is believed that is why atypical antipsychotics theoretically have a less incidence of extrapyramidal symptoms. Atypicals are also reported to be more effective for cognitive dysfunction and negative symptoms than typical antipsychotics. Atypical antipsychotic drugs, but not typical antipsychotic drugs, may facilitate cortical neuroprotection and hippocampal neurogenesis, which might be a part of the action mechanisms of atypicals. MRI studies show that cortical apoptosis is part of the pathophysiology of schizophrenia. And some in vitro studies looked at atypical antipsychotic drugs such as risperidone, olanzapine, and Seroquel on apoptosis with Neuronal cell culture, and it was shown that all of these atypical antipsychotic drugs have protective effects, unlike haloperidol. Neurogenesis includes the proliferation of neuronal precursor cells, the differentiation of neural precursor cells into neurons, and the survival of neural precursor cells in newborn neurons. Taken together, atypical antipsychotic drugs, but not typical antipsychotic drugs, may increase hippocampal neurogenesis, which may also be involved in the action mechanism of atypical antipsychotic drugs. Another mechanism that they believe this neurogenesis occurs is brain-derived neurotrophic factor is well known to have neuroprotective and neurogenic effects in rodent brains, and downstream stimulation of antipsychotic drugs to produce brain-derived neurotrophic factor have been shown, and haloperidol has been shown not to have this mechanism. So this is another potential way that antipsychotic drugs can have benefits that the first generation drugs may not. Atypicals also have a vast pharmacological profile. They hit more serotonin receptors, and they have less affinity for dopamine receptors, but still hit a lot of the dopamine receptors. And they also have more noradrenergic receptor affinity, which all contribute to their atypicality profile. They have preferential mesolimbic binding, so they're less likely to have these negative symptom side effects or cognitive symptom side effects. And the atypicals also have a faster dissociation of the antipsychotic from the dopamine 2 receptor. Sometimes they use the words irreversible for first generation antipsychotics versus reversible for the second generation to describe the binding on the dopamine 2 receptor. First generation antipsychotics, especially haloperidol, are potentially neurotoxic, and it's been shown in molecular psychiatry studies that haloperidol can contribute to cellular apoptosis and can cause damage in the brain, which can lead to extrapyramidal symptoms, side effects, and neurodegradation. Let's look at the receptor pharmacology for the atypical antipsychotics. Here is an image I got from a Shaw textbook. It shows a lot of the receptors that atypical antipsychotics could potentially bind to. It's a good illustration to show the vast pharmacological activity on receptors of these drugs. In addition, each one of these receptors has a different benefit or potential adverse drug reaction or limitation, such as the 5-HT2A or 1A can help mood and cognition. Histamine 1 can help insomnia, but it can also make somebody sleepy. And then there's serotonin reuptake inhibitor, norepinephrine reuptake inhibitor, which we see with ziprasidone. It's important to note that not all atypicals bind to every receptor. Each atypical has a unique receptor profile. So when we're talking about using more than one antipsychotic in a patient, we should use antipsychotics that have a non-overlapping receptor profile, which could potentially benefit the patient even more. It's also important to note that some typical antipsychotics can bind to these receptors as well. So let's look a little bit more in depth of the receptors. I found a nice chart from an article by Miyamoto. It gives selected receptors and lists their benefits and possible limitations. We can see the dopamine receptors. Dopamine 2 has antipsychotic effect, anti-aggression effect, and a lot of these receptors, the more diverse receptor profile, a lot of them could potentially be pro-cognitive or improve negative symptoms, depending on the receptor. Some of these receptors have limitations, such as worsens cognition and can cause extrapyramidal symptoms. In the dopamine 2 receptors, we also see that with the 5-HT2C receptors. We can see weight gain. They say that the 5-HT2A receptor has no antipsychotic effect in monotherapy, but there's Nuplazid, which can help with Parkinson's psychosis. But this table is just to show that each one of these receptors has their own unique benefit, whether it's antidepressant, improves negative symptoms, anti-aggressive, has a cognitive benefit, or helps with affective symptoms such as anxiety and depression. So here's a continuation of some of the receptors that go into a little bit more detail of the molecular pharmacology. Likewise, with the dopamine, serotonin receptors in the previous slide, these receptors can have a procognitive effect, they can have an antidepressant effect, some can have an antipsychotic effect even, and as well as these receptors, they could potentially have limitations as well. I want to point out the muscarinic 1 receptor, and it has partial agonism. And the reason I want to point this out is because there was a drug that was recently shown to have antipsychotic benefit. The drug is called KarXT, K-A-R-X-T, and it's a M1 and M4 agonist, so it has antipsychotic efficacy that doesn't rely on the dopamine receptor, which is kind of cool. And here is a chart I found from an old textbook I had that the plus signs show the greater amount of the plus signs, the greater affinity of that drug to the receptor. This chart is just kind of show a quick overview. It's not all encompassing, and I question some of it, like aripiprazole has M1 receptor action. Aripiprazole, to my knowledge, doesn't have any muscarinic receptor activity. Maybe they mean that aripiprazole can increase the number of muscarinic 1 receptors as part of its molecular pharmacology. We can also see that clozapine has action on the muscarinic receptor, and actually clozapine has an active metabolite, norclozapine, which also has the mechanism of action of a M1 receptor agonist, which could potentially help with its antipsychotic effect as well. One thing else I wanted to point out on this chart that I question its accuracy is Seroquel. The chart says it doesn't have any effect on the serotonin 1A receptors. Most of the atypical antipsychotics have a partial agonist effect on the serotonin 1A receptors, including Seroquel. The only ones that do not are olanzapine, paliperidone, and risperidone. We can see from this slide that a lot of the antipsychotics can have overlapping receptor pharmacology, but the pharmacological effects deriving from the interaction of the drug with its receptor targets are mainly defined by the unique properties of the drug, not just from its affinity to the target, but the efficacy or intrinsic activity, selectivity, mode of interaction, and residence time. Here is a pretty cool visual for grasping the extreme variety and the mechanism of actions with the antipsychotics and their different binding affinities and how they could potentially overlap and how they can distinguish themselves from one another to create synergy and treating the symptoms of schizophrenia. Now let's look at selected drugs and information about the selected drugs that could potentially help us decide when to use which drug in a certain patient. Chlorpromazine or Thorazine, it began the modern era of psychopharmacology for schizophrenia in the early 1950s. Prior to Thorazine, patients would live out the remainder of their lives in the confines of a hospital, and they'd have treatments that probably weren't very effective, such as bloodletting, lobotomies, which could really ruin a patient's life if they develop schizophrenia, because they'd be required to be admitted to a hospital possibly for the rest of their lives. The first in its class, chlorpromazine, became the gold standard against which other first generation and even second generation antipsychotics were compared. It has bioequivalent dosing chart recommendations for other antipsychotics. Higher doses tend to be more effective than lower doses. Higher doses mean greater than 400 milligrams a day. It is the only first generation antipsychotic to be approved for acute mania and bipolar disorder. It has nonlinear pharmacokinetics, so it's hard to predict the concentration. The PO bioavailability is poor. It's only absorbed 4 to 38%. The half-life increases as dose increases, so if somebody is on a smaller dose, they may need to be taking the drug multiple times a day. If they're on a higher dose, they may only need to take it once a day. Chlorpromazine is metabolized by and a strong inhibitor of the CYP2D6 enzyme. Most psychotropic drugs are metabolized by a CYP2D6 enzyme, so we have to be careful of drug-drug interactions with chlorpromazine. It's highly protein-bound like most psychotropics. Chlorpromazine is indicated for its anxiolytic, antidepressive, and anti-aggressive properties. Chlorpromazine pharmacodynamics vary, but may lose some serotonergic properties within the body. Adverse drug reactions include Thorazine has the highest risk of seizures. It also has sedation, metabolic syndrome, orthostatic hypotension, extrapyramidal symptoms, and anticholinergic effects. Decreasing the dose of Thorazine to less than 600 milligrams a day reduced the risk of onset of extrapyramidal symptoms to levels equivalent with those of second-generation antipsychotics, which are said to have less extrapyramidal symptom side effects. Next, let's look at haloperidol. Haloperidol is by far the most frequently used comparator drug in studies. It's efficacious against positive symptoms of schizophrenia, but may have little effect on negative symptoms. It's the first-line agent in the treatment of psychotic agitation. Pharmacokinetics include being metabolized by CYP2D6 and CYP3A4 enzyme, and it's also a moderate inhibitor of both, so we have to be careful of drug-drug interactions. The half-life is 24 hours, but can be dosed 1 to 3 times a day, depending on patient response. Smoking causes a 44% in haloperidol clearance and decreases the serum concentration by 70%. Haloperidol has 22 metabolites, and some may be active. Reduced haloperidol actually blocks sigma-1 receptors that may potentiate the effects of opioids and will help patient take less opioids and potentially be weaned off it, or have pain relief with less opioids. Sigma-1 receptor is interesting because it can help with it's being studied to help with a lot of conditions, including epilepsy, depression. And then there's the pharmacodynamics. Haloperidol is highly selective for the dopamine 2 receptor and has a lack of polypharmacology, which can be a positive for Tourette's and OCD treatment, which are thought to be caused by excess of dopamine. Haloperidol is actually potentially neurotoxic, and there's an article about this. It's been shown to contribute to brain loss over time. It has reduced neuronal cells viability, causing apoptosis, necrosis, and increasing oxidative stress. And it's linked to secondary effects such as 50% of patients experiencing extrapyramidal symptoms. Fluphenazine is another drug that I see frequently used. It's also available in a long-acting injectable. It's a phenothiazine, so it shares a molecular structure similar to Thorazine. Of the antipsychotics, it has the strongest affinity for dopamine 2 receptors and blocks dopamine 2 receptors in the limbic, cortical system, and basal ganglia. Its pharmacodynamics and kinetics, it's a CYP2D6 substrate. The half-life is 15 hours with a time to peak of 2.8 hours and is usually dosed 2 to 4 times a day. Fluphenazine shares similar pharmacodynamic properties to Thorazine, but may be 40 times more potent at some receptors. Smoking increases fluphenazine clearance by a factor of 1.67 and also by the long-acting injectable by 2.33. It could require a dose increase of up to 133%. Fluphenazine does have adverse drug reactions due to its potent dopamine 2 receptor. In a head-to-head trial of fluphenazine long-acting injectable versus haloperidol long-acting injectable, Fluphenazine-treated patients had higher risk of akinesia, akathisia, and Parkinsonism. Fluphenazine has the lowest seizure risk, along with haloperidol, of the antipsychotics. It's a high-potency antipsychotic, so it has higher risk of neuroleptic malignant syndrome. It has a lower incidence of sedative and hypotensive effects compared to Thorazine, and is also contraindicated in hepatic impairment, so we have to be careful to monitor somebody's liver function tests or Child-Pugh score if we suspect hepatic impairment before starting fluphenazine. It may not be recommended first line due to high risk of side effects. Clozapine, it has a vast pharmacological receptor profile. It covers a lot of serotonin receptors, dopamine receptors, and noradrenergic receptors as well. It may be superior to other antipsychotics in treatment-resistant schizophrenia, suicide risk, physical aggression and violence, hospitalizations and overall treatment costs, substance abuse relapses, potentially lower mortality, and it's least likely to exacerbate movement symptoms for patients with comorbid schizophrenia and Parkinson's. It has a wide range of psychopharmacology, and mechanism is encapsulated under the dopamine-serotonin antagonism theory, NMDA receptor hypofunction hypothesis, and cholinergic hypothesis of schizophrenia. So it covers a number of thoughts on the pathology of schizophrenia. It also has an active metabolite, norclozapine, which has M1 agonism, which is unique. And we talked about that earlier, how a new antipsychotic underworks CAR-XT is a M1 and M4 agonist, so this could potentially be what gives clozapine its superior efficacy. Clozapine is metabolized by CYP1A2 and has possible linear kinetics, so we could potentially estimate its serum level based on dose. It has 5 box warnings, including agranulocytosis, which requires a REMS program. Someone has to get their blood monitored either weekly, bi-weekly, or monthly to check their absolute neutrophil count to make sure they do not have this agranulocytosis and be at higher risk of infection. It also has seizures, myocarditis, and other cardiovascular and respiratory effects, and like all antipsychotics, increased mortality in elderly patients with dementia-related psychosis. It's most likely to cause cardiometabolic effects, and is titrated slowly due to the risk of orthostatic hypotension. It has a low incidence of extrapyramidal symptoms and no effect on prolactin levels. Risperidone has a chemical structure that is a hybrid between a butyrophenone like haloperidol type antipsychotic and trazodone like antidepressants, and it has a similar receptor profile to those drugs. It's a potent atypical antipsychotic with antagonist binding affinity at serotonergic, dopaminergic, adrenergic, and histaminergic receptors, lacking any affinity for muscarinic receptors. It has an active metabolite, paliperidone. It has a strong affinity for serotonin 7 receptors and has some alpha-2 adrenergic receptor blockade, which could contribute to precognitive and antidepressant effects. It's a strong antagonist on serotonin receptors 2A and 2C, which could help with negative symptoms and cognitive symptoms. Risperidone and paliperidone and olanzapine are only atypical antipsychotics that do not have serotonin 1A agonist properties. The expert consensus guidelines suggested that clozapine and risperidone would be a good first-line choice for chronic aggression schizophrenia. Adverse drug reactions, it can cause weight gain and hyperprolactinemia. For hyperprolactinemia, they usually recommend adding Abilify to risperidone-induced hyperprolactinemia. It has dose-dependent extrapyramidal symptom, and 60 to 70% of patients have extrapyramidal symptoms at high dosages greater than 6 milligrams a day. Pharmacokinetics, it has CYP2D6 metabolism, hepatic and renal dosing. Its half-life is 3 hours in rapid metabolizers and 20 hours in poor metabolizers, and is dosed 1 to 2 times daily. Paliperidone is the active metabolite of risperidone, and it has a possible mood stabilizing effect similar to lithium and Depakote. Paliperidone is one of the most researched and is probably effective for the reduction of hostility among inpatients with schizophrenia spectrum disorders. The paliperidone receptor profile indicates that in addition to antipsychotic efficacy, it can also be precognitive, have antidepressive properties, and can also improve quality of sleep. Adverse drug reactions may have less extrapyramidal symptoms compared to risperidone due to its more rapid dissociation from dopamine 2 receptors. However, I can't say there's no EPS symptoms because I used to be on Invega, which is a paliperidone long-acting injectable, and I was also on Zyprexa at the time, so I was on 2 antipsychotics, and I developed akathisia, which I think had more to do with the paliperidone. Paliperidone may cause lower weight gain and orthostatic hypotension compared with risperidone. It can also cause hyperprolactinemia. There's less of a concern of drug-drug interactions with paliperidone due to it being primarily eliminated unchanged in the kidney. And because of this, there is guidance of dose based on the renal function. It's dosed usually once daily, and in clinical trials it was dosed in the morning. Lorazepam is approved for schizophrenia and for the treatment of acute bipolar depression. It is effective for both positive and negative symptoms of schizophrenia. May be beneficial for treating cognitive and memory deficiencies. It does not possess any anti-muscarinic or antihistamine activity, which could contribute to cognitive deficiencies and disrupt memory and learning. It has a high affinity for a number of receptors that improve cognitive function. Lorazepam is metabolized by CYP3A4, so we have to be careful for drug-drug interactions and CYP3A4 inducers or inhibitors. A key administration tip is food affects lorazepam. It increases the Cmax and area under the curve by 3 times and 2 times respectively. It's recommended to take lorazepam with 350 to 1,000 calories of food or within 30 minutes of eating. Steady state is reached within 7 days. Lorazepam requires once daily administration with a half-life of 20 to 40 hours. For the adverse drug reactions, there are no clinically significant differences between lorazepam and placebo in the measure of extrapyramidal symptoms. It has a benign profile in terms of cardiometabolic effects, and if switched to lorazepam, patients can have a reversal in cardiometabolic effects even. Lorazepam has the highest relative risk of akathisia compared to aripiprazole and asenapine. Lorazepam also has an increased risk of anxiety, but not agitation associated with that anxiety, and is recommended to be given standalone and not with anticholinergics for extrapyramidal symptoms, especially since lorazepam compared to placebo, there were not significant differences in extrapyramidal symptoms. Geodon has a vast receptor profile. One of the things that's unique about Geodon, it has activity on the serotonin transporter and the norepinephrine transporter. So it can be a serotonin reuptake inhibitor and norepinephrine reuptake inhibitor, like a lot of antidepressants. So it can treat positive and negative symptoms of schizophrenia, as well as treating symptoms of anxiety and depression. Serotonin and norepinephrine reuptake blocking properties might contribute to its potential antidepressant and anxiolytic properties. It has the highest serotonin 2A to dopamine 2 affinity ratio of any currently available antipsychotic, at least of the selected ones we looked at. Iloperidone or Fanapt also has a high ratio, but I don't see that used often. Geodon has an intramuscular formulation, which is highly effective in cases of acute psychosis. Adverse drug reactions, QTC prolongation is highest of second-generation antipsychotics with an increase of 10 milliseconds on average. It has a weight-neutral profile. It has a low propensity for extrapyramidal symptoms and cognitive deficit. I did have a friend who was on ziprasidone, and he had developed some form of rabbit syndrome where he kept sniffing, and it was an extrapyramidal symptom like that he couldn't control. Pharmacokinetics, it's a minor CYP enzyme metabolism and is primarily metabolized via glutathione and aldehyde oxidase, so it has less drug-drug interactions than most other antipsychotics. The half-life of 7 hours gives recommended twice-a-day dosing. Acenapine or Sapphirus is one of the more recent antipsychotics approved. As a chemical structure related to mirtazapine and shares all the pharmacological binding properties of mirtazapine plus others, is approved to treat schizophrenia and bipolar I disorder, including mixed symptoms and acute mania. It differs from other atypical antipsychotics by its breadth of its activities at other serotonin receptors. It also has a strong affinity for antagonism at the following receptors listed, at a lot of serotonin receptors. And they all have greater affinities than the dopamine 2 receptor. Acenapine, of the dopamine receptor subtypes, it has a higher affinity for the dopamine 3 subtype of the dopamine 2-like receptors than for dopamine 2 itself, a property shared with cariprazine. It differs from other antipsychotics in that it is absorbed through the oral mucosa from a sublingual tablet. No food or drink for 10 minutes to let drug dissolve under the tongue. It may be an ideal treatment option in a patient who is suspected of cheeking. The pharmacokinetics, it's metabolized by CYP1A2. It inhibits CYP2D6, and it's the only second-generation antipsychotic that alters the pharmacokinetics of other medications. So we have to more so watch out for drug-drug interactions with acenapine. Limited bioavailability necessitates twice-a-day dosing. However, it being absorbed through the oral mucosa increases the bioavailability. The half-life is 24 hours, and the time to peak is 0.5 to 1.5 hours. Adverse drug actions, include hypoesthesia as a common side effect, orthostatic hypotension. It has less propensity to cause cardiometabolic disturbances, and it has extrapyramidal symptoms comparable to other atypical antipsychotics. Seroquel, it has a similar structure to clozapine, is approved for the management of acute and chronic psychotic disorders, anxiety, acute phase of mania, and bipolar depression. I also see it used for insomnia in those who have schizophrenia or bipolar. The dose for insomnia is less than the dose for anxiety and depression, which is less than the dose for schizophrenia. Seroquel is very atypical because it causes virtually no extrapyramidal symptoms at any dose and is the preferred atypical antipsychotics for Parkinson's, along with clozapine, excluding pimavanserin, which has that specific indication. Norquetiapine is the main active metabolite, and it has activity on the norepinephrine receptor, and it's a HIT inhibitor, so it can increase the norepinephrine levels and have its anti-anxiety effect. It has complex pharmacology and has no appreciable affinity to muscarinic receptors, but has high affinity to histaminergic and alpha-1 adrenergic receptors with a lower affinity for alpha-2 receptors. So it can cause sedation, it can potentially cause hypotension as well. The pharmacokinetics, it has a short half-life of 7 hours, so should be twice a day dosing, unless given the extended release formulation. It's a CYP3A4 isoenzyme is involved in the metabolism of Seroquel to its major metabolites. And Seroquel also reduces the clearance of lorazepam by 20%, so we have to look for, especially in the elderly, possibly increased falls associated with the increase in lorazepam and the sedation of Seroquel. Olanzapine, one of my favorite drugs, just because that is what I'm on to control psychosis, and it's been very effective for me. I do have some side effects, but the benefit probably outweighs the risk. Olanzapine has a similar structure to clozapine, and it also has a large receptor profile. Improved mood not only in schizophrenia but also in bipolar disorder and in treatment-resistant depression. It's combined with fluoxetine and the combination tablet Symbiex for bipolar depression and treatment-resistant depression. The superiority of olanzapine over several other antipsychotics and its effects against hostility has been shown, and it also may be more effective in schizophrenia than other atypical antipsychotics, not including clozapine. It's possibly due to the facilitating effect of NMDA, which can favor brain-derived neurotrophic factor expression, which we saw earlier in the slide, which can contribute to neurogenesis, which could help manage the symptoms of schizophrenia. So level 1 recommendation for therapeutic drug monitoring with a target range of 20 to 80 is often used in higher dosage than originally studied and approved for marketing, since there is a sense that higher doses might be associated not only with greater efficacy and effectiveness. I was looking at a workbook from Stephen Shaw, who's he publishes all this literature, and he had a practice case where he had a patient theoretically on 30 milligrams of olanzapine 3 times a day, which I've never seen before. The highest dose of olanzapine I've heard of is 60 milligrams a day, and the highest I've seen is 40 milligrams a day. So that was somewhat unfathomable for me, but I suppose it's can be that high in practice sometimes. Olanzapine is not recommended first line in someone with a cardiometabolic disorder. Pharmacology includes greater dopamine 4 antagonism than dopamine 2 antagonism. This is a property shared with clozapine as well. We don't understand the significance of this. We thought maybe that it also has antipsychotic properties, but dopamine 4 antagonists, pure dopamine 4 antagonists, have not shown to have this antipsychotic property. Pharmacological blockade of serotonin 6 receptors have been shown to produce promnesic effects in a number of memory tasks. Strong antagonists on serotonin 2A and 2C receptors could help with negative symptoms and cognitive symptoms. It's a CYP1A2 substrate with linear kinetics. Its half-life is 21 to 54 hours, so it's typically dosed once a day. I see it dosed twice a day a lot. It comes in an intramuscular formulation as well that is contraindicated in the use with intramuscular benzodiazepine formulations, which we would see this combination in acute psychotic agitation in a patient who may be violent. And I actually read a study that showed this combination did not have, compared to without using this combination, it didn't have extra significant side effects compared to placebo. However, in theory, this could cause respiratory depression, and we want to avoid that possibility. Let's begin to look at what are sometimes termed third-generation antipsychotics. They're the dopamine 2 partial agonists. Aripiprazole is distinguished from earlier antipsychotics by its partial agonist activity at dopamine 2, dopamine 3. A lot of the second generation antipsychotics have serotonin 1A agonists and serotonin 2C receptor targets. Aripiprazole is one of the most potent agents that bind to dopamine 2 receptor. So in some clinical scenarios, when given concomitantly with a dopamine 2 agonist, it can reduce the level of dopamine 2 blockade compared to dopamine 2 antagonist monotherapy, thus reducing the antipsychotic efficacy, especially in a patient who has their hallucinations under control and a strong dopamine blocker. The idea behind these dopamine 2 partial agonists is they'll decrease the dopamine in certain areas of the brain that are too high in dopamine, causing psychosis, and they'll raise dopamine in other areas of the brain that are too low in dopamine and have these negative symptoms. So impulse control disorders and agitation can occur when starting Abilify, possibly due to its affinity to serotonin H2B receptor. I've talked about this before. When I was taking Abilify, it was so crazy. Like, I just got the urge to gamble, and when I was gambling, I would play no limit poker, and I would go in all in on the first hand and lose about $150. Fortunately, I didn't have any money, so I couldn't do that often. But I always had that impulse. It has a low risk of extrapyramidal symptoms and may even reverse hypoprolactinemia. Its most common reported side effect is akathisia, and it has a low propensity to cause cardiometabolic side effects. It is a major metabolic pathway for CYP2D6 and CYP3A4. It has linear kinetics with a bioavailability of 87% and is independent of low-fat food intake. The maximum plasma concentration occurs in 3 to 5 hours and is achieved approximately 14 days after daily dosing. Brexpiprazole is one of the most recent antipsychotics on the market. It's also a dopamine partial agonist. It comes only in oral formulation. It's the second dopamine 2 partial agonist on the market following aripiprazole. It optimizes dopaminergic neurotransmission in between the mesolimbic and mesocortical pathway, which we talked about, 2 high dopamine in one pathway, 2 low dopamine in another. Brexpiprazole and aripiprazole are thought to share the same mechanism, but there are some differences. Brexpiprazole is more potent as serotonin 7 receptors and has no reported serotonin 2C blockade. Binding affinity for serotonin 2A and 1A is 10 times stronger than aripiprazole and may translate into lower extrapyramidal symptoms and perhaps anxiolytic effects or anti-anxiety effects. Brexpiprazole, but not aripiprazole, has strong antagonism at muscarinic 1 receptors, so we could possibly see side effects from that. It has a long half-life of 91 hours, and a steady state is reached in 10 to 12 days. It's metabolized by CYP3A4 and CYP2D6, and dose adjustment recommendations in poor metabolizers, including meds that are inhibiting or inducing. It has renal and hepatic dosing, but not contraindicated. Due to a lack of head-to-head trials, the exact place in therapy is difficult to determine. But I was talking to someone once in a partial outpatient hospitalized program for patients who were recently admitted into a hospital. I was actually in the program. And one of the other patients said, I should try brexpiprazole. It's the only thing that has worked for her. So it could be another addition for something to try in treatment-resistant cases of bipolar disorder or schizophrenia, possibly. Cariprazine, or Vraylar, is the most recent approved antipsychotic, approved within a few months of brexpiprazole. Greater D3 selectivity versus D2 selectivity, which could indicate a procognitive benefit and negative symptom improvement. Cariprazine was significantly more effective on negative symptoms and on functioning than risperidone in patients with predominant negative symptoms of schizophrenia. However, more data is needed to determine if cariprazine has a specific effect on negative symptoms. Pharmacokinetics, cariprazine, the parent molecule, has a half-life of 2 to 4 days. It's metabolized by CYP3A4 and it has 2 active metabolites with similar binding profiles to cariprazine. Didesmethylcariprazine has a half-life of 1 to 3 weeks, and this long half-life is good for poor adherence. Use is not recommended in those with Child-Pugh Class C hepatic impairment or creatinine clearance less than 30 milliliters a minute, renal impairment. We looked at aripiprazole, brexpiprazole, cariprazine, so let's compare them a little bit on their efficacy and their adverse effects. For schizophrenia, all 3 partial agonists have an indication. The number needed to treat for response is lowest with brexpiprazole, 7. For every 7 patients, 1 patient will respond. For number needed to harm, for weight gain, it looks like cariprazine has 34, so it's least likely to have weight gain. And this is also echoed by the likelihood to harm, with a higher number indicating that is less likely to cause weight gain. Number needed to harm for somnolence is lowest with aripiprazole, so it's most likely to cause somnolence, and this is also echoed by the likelihood to harm. Akathisia, we see that most often with cariprazine, judging by the number needed to harm and the likelihood to harm. For bipolar mania, we just have aripiprazole and cariprazine with those indications. So the number needed to treat is better with cariprazine with 5. The number needed to harm is discontinuation is lower with cariprazine, indicating that more patients will discontinue cariprazine. For somnolence, it looks like aripiprazole is more likely to cause somnolence, but there's not that much a difference between aripiprazole and cariprazine. And we see that akathisia is higher with cariprazine as well in the treatment of bipolar mania. For major depressive disorder, we just have aripiprazole and brexpiprazole as adjunct. The number needed to treat is lower with aripiprazole, indicating that it could be more efficacious than brexpiprazole as adjunct in major depressive disorder. But it's hard to tell depending on patient-specific factors and history. So let's look at therapeutic drug monitoring. Therapeutic drug monitoring is done to reduce adverse effects and improve quality of life. Plasma antipsychotic levels can assist in decision making. However, they are a tool, and there are some arguments that laboratory reference ranges are misleading and do not represent well-defined toxicity thresholds. So we may not dictate treatment based on the serum level, but we can use it to determine if it's out of range or lower than range to kind of give us some guidance in the decision-making process. Many schizophrenia patients require and tolerate high plasma levels for adequate treatment response. Therapeutic drug monitoring may be done in the following circumstances or could be indicated: inadequate response, adherence monitoring, toxicity expected, change in alcohol or caffeine intake, decompensation and mental status, change in drug regimen, when prescribing high doses of medication, confirm true treatment resistance, and identify rapid elimination. So here is an example of select antipsychotics in their target therapeutic range according to therapeutic drug monitoring guidelines for psychotropic medications. Lithium is not an antipsychotic, but I wanted to put it on here to show that it has a level of recommendation of 1, and we see that with antipsychotics as well. So technically, with these antipsychotics, we should be measuring the serum levels just like we do lithium. Haloperidol has a level of recommendation of 1. It has a target therapeutic range of 5 to 17. It's also listed as 1 to 10 in other guidelines, but I see 5 to 17 more often. Higher levels can be tolerated in patients under long-term high-dose therapy due to adaptive changes. An apparent half-life for Haldol-Dec is 17 days. Fluphenazine, it has a therapeutic range of 0.5 to 2. It says 1 to 10 in other guidelines, but I have never seen it as high. I have never seen it above 3, so 0.5 to 2 is the more accurate one. It also has a level of recommendation of 1. The half-life for the long-acting injection is 14 days, and that's given every 2 weeks. Clozapine has a therapeutic reference range of 350 to 600. I've also seen 200 to 400 or even up to 1,000. And it also has a level of recommendation of 1. These level of recommendations, they don't give us guidance on how often we should do the serum levels, just that is a good idea in guiding therapy. The major metabolite of clozapine, norclozapine, has an unclear antipsychotic activity, and the therapeutic reference range seems likely to be lower in pediatric patients. So oftentimes with the clozapine serum level, we also get the norclozapine level. And if there's a high ratio, we can say, hey, the CYP enzymes are saturated, or we could tolerate a higher clozapine dose if there's a lower ratio. Olanzapine also has a level of recommendation of 1 with a target therapeutic range of 20 to 80. And I've seen an olanzapine level at 124.4, and we decided to decrease the patient based on that level because the patient was sedated, was having possible adverse effects due to the olanzapine, and that could be an indication of, hey, we should try to get into a therapeutic reference range. There's the risperidone plus the paliperidone metabolite, and together the range is 20 to 60. With risperidone, adverse reactions correlate with drug concentrations. To avoid neurological adverse drug reactions like extrapyramidal symptoms, greater than 40 nanograms a milliliter should be targeted only in cases of insufficiency or absence of therapeutic response. And then there's paliperidone, the active metabolite of risperidone. It also has a similar therapeutic range as risperidone, 20 to 60, and it has a level of recommendation of 2 as well. A therapeutic option for some patients would be to use long-acting injectables. It has a number of advantages. Some guidelines recommend consideration of a depot or long-acting injectable after relapse of symptoms. We often see somebody started on a long-acting injectable if they're on probate and on forced medication. Long-acting injectables can be used at any point in time for patients with schizophrenia and should not be reserved only for cases of non-adherence to oral meds. Long-acting injectables have notable advantages and disadvantages the prescriber and the patient must weigh before initiating a patient on them. Advantages include decreased mortality of long-acting injectables, possibly due to the benefit of controlling symptoms better. The patient is less likely to do harm to themselves during an active episode of schizophrenia and more likely to be stable and put themselves in less danger and have less mortality. Other advantages includes avoids first-pass metabolism, improved adherence, reduced pill burden, regular interaction between patient and medical staff, steady release of medication and fewer peak-trough side effects, and reduce of overdose. Disadvantages include reduced dosing flexibility. So if somebody's having an adverse reaction, what are we going to do? It's being constantly administered over the course of a number of weeks. We can't just stop the med. Injection site reactions, delayed time to reach steady state, which we can fix by having an oral overlap. Delayed disappearance of adverse drug reactions following discontinuation. It can be viewed as more coercive or stigmatizing than oral medications, and a patient can feel like they have to be on the medication and are monitored more closely. And they are also expensive. How to use. Oral tolerability should be established before initiating any long-acting injectable. For all long-acting injectables, it is crucial to establish tolerability with the oral formulation. This way, we know how the patient responds to it, if it works, if they have any side effects. So we aren't putting all our dollars, our chips in one stack. Long-acting injections have recommendations on dosing based on concomitant drug therapy, oral dose taking, and oral overlap needed. Dosing adjustments required based on drug interactions and comorbid disease states as well. Dosing parameters vary due to different drug release mechanisms and intended time to response. The elimination rate constant remains the same after conversion to active drugs. Misdose recommendations are in the prescribing information and offer good guidance on what to do if a patient misses an appointment to get the injection and how to make up for that. Administration techniques are also listed in prescribing information as well. Haloperidol decanoate is a drug I see occasionally in patients as a long-acting injectable. This drug is synthesized via esterification to a long-chain fatty acid, which is the decanoate. The esters are then dissolved in purified sesame oil, so if somebody's allergic to sesame, this would not be the drug for them. It comes in concentrations of 50 milligrams of ml and 100 milligrams of ml. Absorption rate constant is rate limiting step. This is also known as flip-flop kinetics, where the rate of absorption is slower than the rate of elimination, and the concentration of the compound depends on the rate of absorption. It could take as long as 3 months to achieve steady state. There is a loading dose that can be done is 20 times the daily oral dose. The initial dose should not exceed 100 milligrams. If greater than 100 milligram dose should be administered in 2 injections. Maximum of 100 milligrams initially, followed by the balance in 3 to 7 days. This is what they recommend in the packaging insert. In practice, I don't really see this followed as much. But the reason they do this is if a patient has an acute reaction, it won't be as bad with the higher dose. After the loading dose is followed by 10 to 15 times the oral dose for subsequent doses. Recommend to continue oral dose for at least 7 days. The maximum volume per injection site should not exceed 3 milliliters, and a 21 gauge needle is recommended. It also requires a Z-track method of administration. This is a special technique that is used when administering long-acting injectables to prevent the leakage of the drug outside the muscle. Here's an example of a practice problem on how we transition somebody from oral haloperidol to the long-acting injectable in a loading dose and also a maintenance dose. So if somebody's taking 5 milligrams of Haldol PO BID, the conversion to long-acting injectable is 1 to 20. So haloperidol decanate time 1 dose, and then 10 to 15 milligrams IM haloperidol decanate every 4 weeks. So the first dose is 10 milligrams oral haloperidol times 20 equals 200 milligrams haloperidol decanate intramuscular times 1. So we give 100 milligrams, and 3 days later we give another 100 milligrams. And then for the maintenance dose, we do 10 milligrams oral haloperidol times 10 to 15, which would give us 100 to 150 milligrams of haloperidol decanate IM every 4 weeks. This is somewhat interesting. The reported bioavailability of haloperidol increases as we have more subsequent doses, so a dose reduction to 10 to 15 times that of the oral recommendation is recommended. That's why we have that decrease in the maintenance dose. And then we have a non-loading dose regimen, which consists of oral overlap of haloperidol for at least 7 days. There's a fluphenazine decanoate, which is similar to haloperidol decanoate. It also has esterification that slows the rate of release of the drug from fatty tissues and prolongs the drug's duration of action. It is also suspended in sesame oil, which further delays the rate of release. It's in a concentration of 25 milligrams a milliliter. And we talked about how smoking increases the fluphenazine decanoate clearance. Haloperidol and fluphenazine decanoate are really the only two that require Z-track method of administration, but honestly, all the long-acting injectables would benefit from Z-track method of administration. Repeated injections at the same site could potentially lead to reduced vascularization and thus lower absorption, so we recommend to rotate sites. The onset of action is within 24 to 72 hours. The duration of action is usually 1 to 6 weeks with an average of 2 weeks. I usually see this dose every 2 weeks, and the intramuscular dose is usually 1.25, the total daily oral dose, every 2 weeks, but can be higher in acute psychosis. How about we look at the Z-track injection technique? Like we talked about, it's recommended to be used in haloperidol decanoate and fluphenazine decanoate. However, using the Z-track method when administering all long-acting antipsychotics would improve absorption of the drug. I have right here the Z-tracking technique. Basically, you just stretch the skin away, then insert the needle at a 90-degree angle, aspirate the needle, and wait 10 seconds, then withdraw the needle and release the skin, allowing the displaced tissue to seal the needle track and to not allow the drug to leak out. Aripiprazole Maintaina is another long-acting injectable. It requires reconstitution prior to administration. Oral aripiprazole must be continued for 2 weeks after the initial dose of aripiprazole Maintaina. The initial and usual maintenance dose is 400 milligrams a month, but can be reduced due to drug interactions or tolerability. I've seen in a patient have 400 milligrams of Maintaina every 3 weeks just because it's believed she was a rapid metabolizer because she started to decompensate after 3 weeks. Maintaina reaches steady state after the 4th month injection. Dosing window is no sooner than 26 days and less than 5 weeks. If misdosed by more than a week, restart concomitant oral aripiprazole for 14 days with the next administered dose. There is Aristada or aripiprazole Laraxel. It is a prodrug of aripiprazole. Aristada and Sustenna are available in pre-filled syringes. Sustenna is Invega Sustenna, and they're unique because they do come in pre-filled syringes. They should be shaken but do not need reconstitution. Low solubility causes average absorption half-life of 4 weeks. The maximal drug concentrations are reached in the blood in 5 to 7 days. The mean apparent terminal elimination half-life is 30 to 47 days. And there's 2 methods for initial dosing. One is a 3-week oral overlap, and the other is a 1-day oral overlap with 2 injections, the Aristada Initio and Aristada Laraxel. Aripiprazole Laraxel. And it's important to note that Aristada Initio is not interchangeable with other Aristada strengths, and there are dose adjustments in the package insert for CYP 450 considerations. And at the bottom here, I have a conversion chart from the oral aripiprazole dose to the intramuscular Aristada dose and the PO overlap. The risperidone consta is a unique microsphere formulation that is given every 2 weeks. As well as schizophrenia, it also has a label indication for bipolar 1. This long-acting injectable must be refrigerated. It requires reconstitution prior to administration as well. Measurable serum concentrations are not seen until approximately 3 weeks after single dose administration. After this, the risperidone is gradually released in a sustained manner for 4 to 6 weeks. Kinetic studies have shown that oral doses of 2 mg, 4 mg, and 6 mg are equivalent to 25 milligram, 50 milligram, and 75 milligram of the constant respectively. But current dosing conversion recommendations are 25 milligram for the 2 milligram, 37.5 milligram for 4 milligrams oral, and 50 milligrams of the Consta for 6 milligrams oral, and 50 milligrams every 2 weeks based on dose response studies. An interesting study, it was a 6-month randomized trial of patients with first episode schizophrenia within the past 2 years, found that patients treated with risperidone long-acting injectable had more stable white matter volume when compared to patients with oral risperidone, which is an interesting outcome since schizophrenia patients on MRIs have shown to have less white matter volume. So the risperidone long-acting injectable seems to have more an effect on that. Risperidone Perseris is one of the most recent long-acting injectables come out. It is like risperidone Consta, except it's a once-monthly injection of risperidone. And it has a specific microsphere formulation, but it uses larger molecules to slow the release. So this is also stored in the refrigerator, but should be room temperature when giving the injection. It can be stored in the unopened packaging at room temperature for up to 7 days prior to administration. The injection kit consists of 2 syringes. One contained liquid polymer and the other contained risperidone powder. Comes in 90 milligrams or 120 milligrams monthly. 90 milligrams corresponds to 3 milligrams a day of oral risperidone, and 120 milligrams corresponds to 4 milligrams a day of oral risperidone. Anything less or more than those dosages may not be candidates for Perseris. One thing that's unique about Perseris is it's only atypical given subcutaneously and it's administered in the abdomen. Clinically relevant levels of drug reach after first injection, so no need for oral overlap. There's 2 absorption peaks. First is 4 to 6 hours due to the initial release of the drug during the depot formation process, and the second is 10 to 14 days post-dose and is associated with the slow release of risperidone from the sub-Q depot. Patients should be counseled that they may have a lump at an administration site for several weeks and that they should not rub or massage the injection site. Invega Sustenna is a common long-acting injectable that's used in a variety of different patients. I was on it during my psychosis. My closest friend is on Invega Sustenna with some success. Invega Sustenna is an extended release aqueous-based nanosuspension. It has low solubility. The buffer penetrates muscle tissue and leaves a collection of paliperidone palmitate particles locally at injection site, and then from there on the particles dissolve slowly to exhibit biphasic absorption into systemic circulation. The first injection should be into deltoid muscle, but the maintenance injections can be deltoid or gluteal. There's an absorption difference between the sites, but it's not to be believed to be clinically significant except in that first dose. It requires an initial loading dose of 234 milligrams plus 156 milligrams 1 week later, plus minus 4 days. However, if a patient was previously controlled on another long-acting injectable, no initial loading dose of Sustenna would be required. Use is not recommended in patients with creatinine clearance less than 50 milliliters a minute. There are mixed dose recommendations, and basically, if it's less than 6 weeks, resume normal dosing. If it's greater than 6 weeks, add another injection of a same dose 1 week later. So it's like a small loading dose. So there are dose conversions from oral tablet of paliperidone to Sustenna. 3 milligrams is 39 to 78 milligrams a month of Sustenna, while 12 milligrams oral of paliperidone is equivalent to 234 milligrams a month of Sustenna. Risperidone Consta, if somebody's on that every 2 weeks, there's actually an conversion to Invega Sustenna every 4 weeks if a prescriber decides they want to switch from Risperidone Consta to Invega Sustenna for whatever reason. And that's 50 milligrams of Consta every 2 weeks is equivalent to 156 milligrams every 4 weeks of Invega Sustenna. There is also Invega Trenza, which is paliperidone palmitate. It can only be used if the patient has been receiving 1 month paliperidone palmitate injections for at least 4 months, while the last 2 months at the same dose. Invega Trenza is a 3-month injection, so it's given every 3 months. It uses nanocrystal technology similar to the paliperidone 1-month injection, but with increased particle size, allowing for extended sustained release. Dosing conversion from Sustenna to Trenza is as shows: 234 milligrams every 4 weeks equals 819 milligrams every 3 months of Trenza. We can extrapolate that from the oral dose. 12 milligrams PO of paliperidone a day must then equal 819 milligrams every 3 months of Trenza. Missed doses should be avoided, but patients may be given the injection up to 2 weeks before or after the 3-month time point. Release of drugs starts as early as day 1 and lasts for as long as 18 months, so there's no need for oral overlap. The half-life is longer in the gluteal as well, but not clinically significant. It's a novel formulation that helps improve clinical outcomes by delaying release and further alleviating issues with poor compliance and benefits, especially those with limited access to healthcare. The final long-acting injectable currently on the market is olanzapine Relpriv. It has a risk mitigation strategy program for the potential of post-delirium sedation syndrome adverse effect. A patient has to be monitored for 3 hours after they receive this injection for confusion, altered mental status, fainting, and they believe this occurs when a vessel is penetrated by the injection instead of it being intramuscular. The prescriber, healthcare facility, patient, and pharmacy must all be registered in the patient care program in order to administer this medication. Upon intramuscular administration of olanzapine pamoate, the continuous dissolution of the salt begins immediately. It forms a salt that is poorly soluble and has slow dissolution at the gluteal muscle injection site. A measurable serum concentration is reached within minutes to hours after injection, so oral overlap is not necessary. Therapeutic serum concentrations are generally reached within the first week of initiation and steadily decline over the next few weeks, allowing for 2 or 4 week dosing. During the first 8 weeks of Relpriv therapy, the dose is recommended to be higher than after 8 weeks. In practice, I never see the dose actually go lower. At least in my hospital setting, we don't really lower the dose that much, but it's something to do once patients get out in the community to be on the lowest effective dose. And the reason they recommend a lower dose after 8 weeks is because they have a steady state concentration and we don't want to have a stacking effect, so we decrease the dose so it doesn't have that stacking effect. Bioequivalence to oral therapy, around 300 milligrams intramuscular every 2 weeks equals 20 milligrams PO a day. And this is a summary of the long-acting injectables, and it kind of just goes over where we talk about what we talked about, whether it requires oral overlap, the administration injection site, the typical dose, what dosage forms the long-acting injectables come in. It's important to note when one of these long-acting injectables, say like risperidone, requires PO overlap, it's important to be careful to discontinue the oral medication after those 3 weeks instead of having both the oral and the injection just be continued on. We need to be careful not to have too high of a dose of risperidone than necessary, or any medication that requires PO overlap. So here we have the dose conversions from oral to the intramuscular regimen. We have the therapeutic max and the time to steady state, and also the half-life. The next thing we need to discuss is the discontinuation and switching of antipsychotics. A lot of times in practice, an antipsychotic may not be effective, and we have to switch or discontinuing an antipsychotic, and we have to talk about strategies on how to do that. There's no specific information regarding switching between antipsychotics or long-acting injectables. There's the exception of Invega Sustenna, which, if you remember, when starting Invega Sustenna, if they've already been on a long-acting injectable, just start the Sustenna at the next dose. There are 5 options for switching between antipsychotics, though. Abruptly switch, which we may see if somebody's having acute side effects. Descending taper switch, which is probably one of the best strategies next to cross titration. Ascending taper switch, and plateau cross taper switch, and we'll talk about these. Switching from clozapine, olanzapine, and Seroquel to another second-generation antipsychotic appears to be most problematic. Rebound psychosis can occur when switched to aripiprazole, paliperidone, or risperidone. This is likely due to these drugs not having muscarinic antagonists, so you get cholinergic rebound, which can cause psychosis. And aripiprazole is a partial dopamine receptor agonist, so when you switch to it, you don't get that dopamine blockade anymore, and you can have a relapse in symptoms. Olanzapine and Seroquel should be tapered over a period of 3 to 4 weeks. The dose of clozapine should be decreased over 4 weeks or more. Gradual reduction of dose with or without the addition of an anticholinergic agent or benzodiazepine is recommended when a switch to an antipsychotic with a lower muscarinic receptor affinity is indicated to prevent cholinergic rebound, which we talked about. When tapering, we need to take into account the half-life of medication and its daily dosing and patient-specific factors. Patient may also need increased monitoring for discontinuation symptoms, rebound symptoms, and agitation. When discontinuing antipsychotics, we should taper the dose down over several weeks to months. We have to do it very slowly. I used to be on 2 antipsychotics, 234 milligrams a month of Invega Sustenna, and also 20 milligrams a day of olanzapine. Fortunately, we've tapered that down gradually over the course of years, and now I'm just on a low dose of olanzapine, which has been which has kept me stable and I've had a lot of success. Discontinuing is dependent on patient characteristics and avoids withdrawal symptoms and decrease the risk of relapse. There are antipsychotic dose equivalents, so if you're ever wondering how much of haloperidol is equivalent to Thorazine, this table kind of tells you. The first generation antipsychotic drugs, the dose equivalents are probably more accurate with one another. The second generation antipsychotics, there is evidence, that's why it's in this table, of the dose equivalents between one another, but there's less evidence compared to the first generation antipsychotics. So we can kind of see what dose is equivalent to another dose, and these are called Thorazine equivalents. The benefit of Thorazine equivalents is it can kind of give us an idea of the target dose we're looking for in the antipsychotic we're switching to. So when switching, we have to be mindful of receptor pharmacology. If we switch somebody from one antipsychotic to another antipsychotic that doesn't have an affinity for a certain receptor, say antihistamine, histamine 1 receptor, they could have a rebound effect of anxiety, agitation, insomnia, restlessness, and even extrapyramidal symptoms or akathisia. Like we talked about with dopamine 2 receptor, if we discontinue someone from a potent dopamine receptor to a partial agonist or a weak dopamine 2 receptor, we can have rebound psychosis, mania, agitation, akathisia, and withdrawal dyskinesia. Alpha 1 receptors, we can have rebound tachycardia and hypertension. And even with the serotonin receptors, like switching from a second generation to a first generation, we may not have those serotonin receptors antagonists, so we could have rebound anxiety, akathisia, psychosis, or decreased appetite. So these are potential corrective approaches in switching, emergent side effects and how to manage them. Akathisia, we start with a lower dose and slow down switch. We could potentially add adjunct treatments to help with the akathisia, such as a benzodiazepine or a beta blocker. Rebound mania and psychosis, it is advised to slow down the titration of the prior antipsychotic and increase the new antipsychotic, add a benzodiazepine or Depakote. Agitation, we slow the switch, increase the dose of the new antipsychotic, add a benzodiazepine or low potency first generation antipsychotic or Depakote. For anxiety, we use lower starting dose, slow the switch, restrict excessive caffeine use. We can use benzodiazepines, antihistamine like hydroxyzine, antidepressant, or gabapentin, which is also used for anxiety. Insomnia, we slow the switch, restrict caffeine use. We can add a sedating second generation antipsychotic like Seroquel, a benzodiazepine, non-benzodiazepine hypnotic like Zolpidem, an antihistamine, or trazodone as well. So we basically looked at the receptor pharmacology and the treatment emergent side effects that can occur when switching from one antipsychotic to another antipsychotic or from discontinuing a certain antipsychotic. And we looked at how we can possibly manage some of these side effects with drug therapy. Let's look at select switching scenarios and the advantage, disadvantage, and when it's recommended to use this scenario. There's the abrupt switching. The advantage is low risk of drug interactions. The disadvantage is withdrawal reactions or rebound reactions. And it's recommended to do abrupt switching in patients with serious adverse events. Gradual switching. Back to abrupt switching, an example of a serious adverse event would be neuroleptic malignant syndrome. And then there's gradual switching as a low risk of withdrawal reactions and hardly any drug interactions. The danger is symptom exacerbation, and this is recommended in patients with a low risk of relapse. And then cross tapering, which is the safest to prevent relapse. Drug interactions make it complicated, and this is recommended for recently stabilized patients. So we know some of the strategies on how to switch. How do we not switch antipsychotics? There are strategies for switching antipsychotics and strategies to avoid to prevent rebound psychosis, aggravation of side effects, or withdrawal symptoms. In general, we should not rush the discontinuation of the first antipsychotic, not allow gaps between two antipsychotic treatments, and not start the second antipsychotic at full dose. And I'm going to add another one. Once we start the antipsychotic we switch to and get to our target dose, we have to make sure that we don't keep the other antipsychotic on the pharmacy profile, because it could potentially lead to inappropriate polypharmacy. So here's a strategy I got from Stephen Shaw and his antipsychotic workbook. It's switching from one sedating antipsychotic to another. And it's recommended to use cross titration. The first antipsychotic is slowly tapered off. The second antipsychotic is slowly added. This can be done over a few days or a few weeks. Even though patient will be simultaneously taking two medications for a short period of time, it is acceptable as it can decrease side effects and the risk of rebound symptoms, and can quicken the successful transition to the second drug. And if we're looking at, I think it was considered the BNF dosing, where you add the percentage of the maximum dose of each single drug, and if the percentage exceeds 100%, then you have too high a doses on your combination antipsychotic. But I'm not sure how much that is used in practice. That is a little tangent I went off of. So here's what we are talking about a little bit, getting trapped in cross titration. It is imperative not to forget to taper the first drugs. Patients may improve in the middle of cross titration, but this should not be the reason to stop the process. And unfinished cross titration will lead to polypharmacy, where the patient takes two drugs indefinitely. And we talked about how polypharmacy may be necessary to use in hard to treat cases, but we need to give an adequate trial of monotherapy first and an adequate trial of the second drug that we use. We can also use benzodiazepines to lead in or top up non-sedating antipsychotics. When patients are agitated or having that side effect from withdrawing from antipsychotics, it may be beneficial to augment with a benzodiazepine just for a short time when the non-sedating antipsychotic is initiated. Once the non-sedating antipsychotic has been titrated to its full dose, then the benzodiazepine can be slowly tapered. During the maintenance phase of the antipsychotic, as-needed benzodiazepine can be used as a top-up approach for breakthrough symptoms. When switching from a second-generation dopamine antagonist to a dopamine partial agonist, you don't want to do it too fast. It is important to give the receptors time to adjust their sensitivity and thus the dose of the dopamine partial agonist may need to be adjusted in order to reach full therapeutic potential. It may be best to initially add the second antipsychotic gradually while keeping the first one at full dose, and to keep both medications on board for a few weeks, just to make sure there isn't breakthrough decompensation or instability. It may also be beneficial to add a benzodiazepine short term for breakthrough anxiety symptoms or rebound anxiety symptoms. In conclusion, antipsychotics are a useful drug and can treat a number of disorders. Knowing the dosing, administration, pharmacokinetics, pharmacodynamics can help decide best care for a patient. The selection of an antipsychotic depends on a number of factors, including side effect profile, symptomatology, patient-specific factors, including history, and evidence in the literature. Therapeutic drug monitoring can be used as a tool in a number of patient case scenarios, and then long-acting injectables are underutilized and should be used more than patients who are just non-adherent to medications. Discontinuation and switching strategies can help improve the quality of life and reduce the risk of harm when discontinuing or switching an antipsychotic. So that is the presentation on antipsychotics. I hope you enjoyed. Let me know if you have any questions or if you want to contribute anything, any additional information. I would greatly appreciate it. Thank you. I hope you have a nice day.